Okay, let's unpack this. Navigating complex health information can feel, well, like trying to find your way through a dense fog sometimes, especially when it touches on something as significant and, let's face it, emotionally challenging as cancer. But being truly informed, really understanding the nuances, that's where the power lies. Today, we're taking you on a journey, a deep dive into the landscape of metastatic breast cancer, often called MBC. And this isn't just about reciting facts, it's about dissecting what it means for someone, understanding the symptoms, both subtle and overt, and exploring the frankly sophisticated and ever evolving strategies for living well with this condition.
And our mission today is really to give you that clarity. We're going to try and distill the core knowledge from the sources you've shared with us. Specifically, there's a detailed transcript focused on understanding MBC. And the aim is to help you grasp the essential facts, understand the implications, which are profound, and hopefully walk away feeling much more confident and informed about this critical health topic. So to lay the foundation, it's crucial to understand that MBC is when breast cancer spreads. It moves beyond its original site to other parts of the body. This deep dive will clarify exactly what that means for a patient, the fundamental shift in treatment goals, and how modern medicine aims to manage it, often for years.
Excellent. Okay, so with that clear understanding of what MBC fundamentally is, let's dive into why this distinction is so critical. What exactly is metastatic breast cancer? And what makes this specific stage so different from early stage breast cancer?
It's crucial to define it clearly. Metastatic breast cancer is, as you said, when breast cancer spreads. It goes to other parts of the body. And these aren't just random locations. It typically moves to places like the bones, the liver, the lungs, or sometimes even the brain. You might also hear doctors call it advanced or secondary or stage 4 breast cancer.
Hmm.
They all mean the same thing.
Stage 4.
Yeah.
Okay.
And here's a truly crucial point, one that immediately reframes, well, everything for a patient. Metastatic breast cancer, with the treatments we have today, cannot be cured.
Wow. That's a stark reality, isn't it? And it immediately shifts the entire perspective for a patient. It moves from, I guess, a fight for a cure to something else entirely.
It absolutely does. It fundamentally changes the patient's journey. The entire goal shifts from aiming for a cure to focusing on long-term management. This redefines everything about how a person lives with the disease, and our source highlights this quite starkly, actually, when it talks about survival rates. So about 4 in 10 people diagnosed with metastatic breast cancer are alive 5 years after diagnosis.
4 and 10.
Right. Now compare that to 9 in 10 people with stage 1 to 3 breast cancer. The difference is profound. It's not just a statistic, it represents a completely different prognostic landscape.
Right.
And because of that, a completely different treatment philosophy is needed.
So it really moves from what might feel like, a sprint against the disease to more of a marathon. Requires a completely different mindset, I imagine, for both the patient and the medical team.
Exactly. Yeah, it's a totally different mindset. And this condition, it isn't always diagnosed right at the beginning, is it? That's another key point.
Right.
While some people are diagnosed with MBC right from the start, a significant number, the source says about 30% of women who previously had treatment for early-stage breast cancer will eventually develop MBC.
30%. Wow.
Yeah. So understanding this distinction isn't just for those newly diagnosed. It's also really important for those who've gone through early-stage treatment and might be living with that, underlying concern about recurrence.
That figure, 30%, really underscores why this deep dive is so vital for so many people listening. So, okay, given that profound distinction you just made, incurable, focused on management, the next logical question is, how would someone even know? How would they know if they were developing MBC? The symptoms aren't always what you'd typically expect, are they? Like, not necessarily a lump in the breast.
That's exactly right. Initially, the symptoms can be very general, almost insidious. Things like persistent tiredness or maybe a poor appetite, just feeling off. But what's critical to understand is how these symptoms often evolve. They become quite specific, depending on where the cancer is spread, almost like a roadmap.
A roadmap. Okay, I like that. So if these general symptoms, like tiredness, could point to almost anything, what are the specific clues? The ones that arise when cancer spreads to particular areas. Let's break that down, because I imagine that's where the really specific indicators lie.
Absolutely. Our source material details this very clearly. Let's take it area by area. If the cancer has spread specifically to the lymph nodes, maybe under your arm or near the collarbone, you might notice new or growing lumps there, or even in the breast area itself. When it's in the bones, common signs can include persistent pain, often in a specific spot like the back or hips, or sometimes unexplained broken bones from, minimal trauma.
Oh, wow. Minimal trauma causing a break.
Yes. If it spreads to the liver, you might experience abdominal pain or perhaps swelling. And a particularly telling sign can be itchy skin or yellowish skin and eyes, which is medically known as jaundice. For spread to the lungs, symptoms often include shortness of breath that doesn't go away, or a persistent cough. Sometimes that cough might bring up blood, sometimes not. And finally, if the cancer has spread to the brain, well, the symptoms there can be quite varied and impactful. Things like persistent headaches, maybe weakness or numbness in the arms or legs, vision problems, and even sometimes noticeable changes in personality or behavior.
That's an incredibly detailed roadmap, as you said. It really shows how varied MBC can present itself. But you touched on something critical the source mentions. A lot of these symptoms could be something else entirely, right? Something less serious. How does someone navigate that ambiguity without, jumping to conclusions? What does the source advise? When should you genuinely worry?
That's a vital question, and the source is very clear on this point. The advice is, if you experience these types of symptoms, and they persist for more than, say, a few weeks, or if you or even your primary doctor have a persistent worry about them, don't ignore it. The recommendation is to contact an oncologist for guidance. Get it checked out by a specialist.
Okay, so persistence is key. Don't dismiss something that lingers.
Exactly. The key is seeking expert advice and being proactive. Don't try to self-diagnose or just dismiss persistent issues. It's about informed caution. Informed caution.
Got it. So shifting back to treatment. If a cure isn't the objective, what is the overarching goal when someone is diagnosed with MBC? How does that reshape the patient's experience and the medical approach? What does it all mean for someone facing MBC treatment?
Right. The primary goals of treatment for metastatic breast cancer are profoundly different from early-stage disease. The focus is really on reducing symptoms, making you feel better, and crucially, helping you live longer, extending life. But it's important to keep reinforcing that, as we've discussed, these treatments will not cure the cancer. The approach is also highly individualized. Doctors don't follow a sort of cookie-cutter plan.
Right. No one size fits all.
Definitely not. They consider a whole range of factors. The specific tumor type, its biology, its size, where it's spread. They also look at what treatments you might have already received, your general health, whether you're pre- or postmenopausal, and even how quickly the cancer seems to be growing. Is it slow-moving or more aggressive?
A truly personalized journey, then. Can you maybe give us a sense of how dramatically those paths might diverge? Like, let's say you have two hypothetical patients. One is premenopausal with a fast-growing HER2 positive tumor, and another is postmenopausal with a slower ERPR positive one. How different would their initial treatment plans likely look?
Oh, that's an excellent way to illustrate it. They could be quite different. For the premenopausal patient with that aggressive HER2 positive disease, the immediate focus would likely be on targeted therapies. Drugs designed specifically to block that HER2 protein. And that might be combined with chemotherapy fairly early on to tackle the rapid growth. Hormone therapy might be less central initially, whereas for the postmenopausal patient with a slower ERPR positive tumor, hormone therapy would probably be the cornerstone. The goal there is blocking the estrogen and progesterone that are fueling the cancer. That could go on for a long time, maybe with less aggressive chemo or chemo introduced later if needed. So yes, vastly different strategies, really tailored to the unique biology of the cancer and the individual patient.
That really illuminates the intricate decision-making involved. It's fascinating. And a central consideration in all these treatment discussions, as the source notes, is something doctors refer to as your quality of life.
Oh.
What does that truly encompass? It sounds important, but maybe a bit vague. What does it mean beyond just feeling better?
It encompasses a great deal, actually. It's a really critical concept in managing MBC. Quality of life means ensuring that treatments don't just extend life, but also preserve as much normalcy, comfort, and function as possible. It's about managing pain effectively, minimizing debilitating side effects like fatigue or nausea, maintaining independence, and really allowing someone to continue engaging in activities that bring them joy and meaning. Family, work, hobbies, whatever it is.
So it's about the whole person, not just the disease.
Absolutely. These aren't just clinical objectives. For patients, these goals translate into precious time, improved comfort, and the ability to live life on their own terms as much as possible. This is why the main treatment categories are often divided into systemic therapy, things that affect the whole body.
Like chemo or hormone pills.
Exactly. Hormone therapy, chemotherapy, targeted therapy, those are systemic. And then there's local therapy, which focuses on specific areas. Think surgery or radiation. And often, a patient might receive both, strategically combined for the best outcome for them, considering that quality of life piece.
That distinction between systemic and local therapy is really helpful. It's not just a list of treatments, is it? It feels like it speaks to a fundamental shift. Instead of searching for one silver bullet, the insight here is the power of a highly adaptive, multi-pronged strategy, a strategy designed to manage a complex chronic illness over the long term.
That's a perfect way to put it.
Okay, so let's dive deeper into some of these specific therapies you mentioned, because they each work in pretty fascinating, distinct ways.
Definitely. Let's start with hormone therapies. As we touched on, these are used if the tumor is responsive to estrogen and progesterone. Doctors call these ERPR-positive tumors. Essentially, the cancer cells have receptors on them. Think of them like docking stations. When estrogen or progesterone docks there, it tells the cancer cell to grow. Hormone therapies work by blocking those docking stations or reducing the hormones available, basically cutting off the cancer's fuel supply.
Okay, starving it out, in a way.
Sort of, yes.
Mhm.
They can be quite effective in shrinking tumors or slowing their spread, sometimes for a very long time. These therapies are also used in earlier stages to lower recurrence risk. For MBC, you can often take them for as long as they're working to control the cancer's growth, maybe years.
Right, so strategically depriving the cancer cells. Makes sense. What about chemotherapy? That's a term most people know, but often associate with really tough side effects. How does it fit into the MBC picture?
Chemotherapy is often suggested if the cancer is not driven by hormones, so ERPR negative, or maybe if hormone therapy has stopped working. The goals here are similar: relieve symptoms, control the cancer's growth, and improve quality of life. Now, with MBC, you might need chemotherapy for a longer duration than in early stages, but the treatment can be quite flexible. Doctors might change the specific chemo drugs used over time, adjust the schedule, or even pause or stop treatment, depending on how well it's working and how well you are tolerating it.
That flexibility sounds crucial for patients.
It really is. It can be given as an IV infusion in a clinic, or sometimes as a pill you take at home. It might be one drug or a combination. And while side effects certainly exist, it's important to know that there are many effective medicines and strategies now to help manage them. It's often much more manageable than people fear. The source mentions several types used for MBC names like taxanes, anthracyclines, platinum agents, plant alkaloids, and capecitabine. Lots of options.
Good to know management of side effects has improved. Okay, and then we have targeted therapies. These sound very modern, very precise.
They absolutely are. Targeted therapies are really at the forefront. These are drugs designed to control cancer by interfering with specific molecules, often proteins involved in cancer cell growth and survival. They work by changing how the cancer cells function at a fundamental level, often based on the specific genetic makeup of the tumor. A key example is for HER2-positive breast cancer. These cancers have too much of a protein called HR2 on their surface, which makes them grow aggressively. So targeted therapies like Herceptin or Perjeta and others specifically block or target that HR2 protein. They essentially disrupt its growth signals, often with fewer effects on normal, healthy cells compared to traditional chemo.
So like precision tools hitting specific targets rather than a broad spectrum approach.
Exactly. That's a great analogy. And like other treatments, they can be given as a pill or an IV drip.
Fascinating. And what about radiation therapy? Where does that fit in?
For MBC, radiation is used very strategically. It's usually a local therapy. The main goals are to shrink specific tumors, relieve symptoms caused by those tumors like pain or pressure, and generally improve comfort. It's often applied if cancer has spread to specific localized areas, maybe a spot on the skin, troublesome lymph nodes, parts of the brain causing symptoms, or specific painful areas in the bones.
So targeted symptom relief in specific spots.
Precisely. But there's also an interesting systemic application. If cancer has spread to several places in the bones, causing widespread pain, sometimes an injection of a radioactive substance can be given. It travels through the bloodstream, gets taken up by the cancer cells in the bone, and delivers radiation directly to those spots. It's a way to kill cancer cells in multiple bone locations and control pain systemically, which is quite clever.
That is clever, addressing widespread bone issues without radiating the whole body externally. And speaking of bones, the source specifically mentions bone health management. Why is that singled out as so crucial?
It's absolutely vital because the bones are one of the most common places for breast cancer to spread. And when it does, it can significantly weaken the bone structure. This increases the risk of painful fractures, sometimes from very minor incidents. It can also cause high calcium levels or pressure on the spinal cord. So to counter this, there are specific drugs used to protect the bones. They help keep them from getting thinner or breaking down. Two main types are mentioned: bisphosphonates and a drug called denosumab, which is an osteoclast inhibitor. Basically, these drugs interfere with the cells that naturally break down bone, helping to preserve bone strength and integrity.
So it's a proactive measure to prevent complications and maintain function.
Exactly. It's a really important part of maintaining a patient's quality of life and physical function when they have bone mets.
Yeah.
But
That's an incredible array of tools in the medical toolkit. It really highlights the personalized, multifaceted nature of MBC treatment today. It speaks to, I think, an unwavering commitment to improving patients' lives, even when a cure isn't the primary goal.
absolutely. And that leads us to the reality of living with MBC long term. Patients will likely need to remain on some form of treatment pretty much indefinitely, unless, of course, they choose to stop it, which is always their right. It becomes an ongoing process of management, monitoring, and adaptation.
Adaptation, meaning if one treatment stops working.
Yes. If one treatment stops being effective, or the side effects become too difficult, the good news is that there are usually other options. This might mean changing medications within the same class, like trying a different hormone therapy, or switching to a different type of treatment, maybe moving from hormone therapy to chemo, or adding a targeted therapy. Or another really important avenue is exploring a clinical trial.
Ah, clinical trials. You hear about those offering new hope. Can you elaborate on their roles specifically for MBC patients?
Precisely. Clinical trials are extremely important in MBC. They represent the cutting edge, the frontier of medical discovery. Participating might give patients access to new, innovative treatments, new drugs, new combinations, new approaches that aren't yet available to the general public. These are carefully designed studies testing the next generation of therapies. For someone with MBC, joining a trial can mean accessing the very latest science. It also means contributing to a deeper understanding of the disease, which is vital for helping future patients.
So it benefits the individual and the wider community.
Absolutely, and the source emphasizes a really crucial long-term perspective here. The goal of treatment today isn't just short-term relief. It's increasingly about controlling MBC for a number of years. This is a significant paradigm shift from, say, a few decades ago.
A number of years. That phrase really stands out. It provides such a crucial shift in perspective, doesn't it? Moving away from thinking of it only as a rapidly fatal disease to one that can potentially be managed effectively for a significant period. It's about living with the condition, more like a chronic illness, rather than just battling it in a short, intense fight.
That's exactly the shift. And many people do live well with MBC now. They manage it with ongoing treatment, tackling the cancer and any side effects, and building fulfilling lives alongside their treatment.
That's incredibly hopeful.
It is. And researchers are constantly discovering more. Through these clinical trials and other research, treatments are becoming more effective, more targeted, often with fewer side effects. The dynamic nature of medical progress here is genuinely remarkable. It offers ongoing hope and steadily improving quality of life possibilities.
Okay. Together, we've really taken a deep dive into metastatic breast cancer today. We've explored what it is, the varied symptoms to be aware of, and we've delved into the complex, but as you say, rapidly evolving world of treatments. We've seen that while it cannot currently be cured, the unwavering focus is squarely on management, on preserving and enhancing quality of life, and extending healthy, productive years.
And I think this journey really reinforces that key takeaway. Knowledge is power here.
Mhm.
Understanding the different therapies, the personalized approach, the importance of quality of life, and the ongoing research. It provides a robust framework for hope, and it empowers individuals, to make truly informed decisions about their care and their future. The dynamic nature of medical progress is just fascinating.
It really is. And that brings us to our final thought for you, our listeners, to mull over. What does it really mean for individuals, for families, for healthcare systems when a disease described as life-threatening and incurable can potentially be managed sometimes for a number of years with ongoing treatment? How does this profound shift reshape our understanding of chronic illness itself, the very definition of what it means to live well, and maybe even the nature of hope in modern medicine? We hope this deep dive helps you continue your own learning, perhaps have more informed conversations, or support others who might be on this journey.